Here we are going to discuss about a very topical and important area of the perinatal and or neonatal infection and vaccination during the pregnancy. So this is just numbers from the viral illnesses in pregnancy over 20 weeks, over a 20-week gestation in South Australia between 2004 and 2014. And as you see, apart from Hep B and Hep C, some of the infection actually has a good number which has been during pregnancy, such as CMV 47, herpes simplex 62, herpes zoster 72, and if you come down, influenza 188, and during the swine flu epidemic, it was 38 from 2010. But really other infections such as pertussis and shingles, and if you look, people are asking why we're doing syphilis. Still, we pick up a good number of syphilis during pregnancy, which is fine. No rubella as such as we could see. And this is a neonatal congenital viral infection between 86 to 2014. And the biggest number was the CMV, as we all know, 59. But also has been a herpes simplex 6, rubella actually 2, and the syphilis, congenital syphilis of 11, and the tox of 8. So I'm going to go to the panel. It has been some changes on experts who are talking this tonight. So it's Dr. Celia Cooper from infection disease, who is an infection disease consultant. Associated Professor Michael Gould, the pediatric allergist and immunologist. Ms. Lynn Langley, midwife and shared care coordinator from Women and Children. Dr. Vanish Bhatia, neonatologist from Women and Children, and Dr. Peter Moller, MFM subspecialist from Women and Children as well. So I'm going to move very quickly to case 1. So this is Michelle. She is 21 years old, unemployed, lives with boyfriend Matthew, also unemployed. This is her first pregnancy, was unplanned, was happy. She booked at 8 weeks, no real past medical surgical specific history. She was told to start pregnancy multivitamin. She opted against first trimester screening and non-invasive parenteral testing. She came at 18 weeks ultrasound and was found that it's a single intrauterine pregnancy, compatible with the dates, but they found echogenic bowel, otherwise nothing else. So they sent her down to the clinic immediately to be reviewed. She was seen by one of the doctors and was reviewed postnatally, and they started some tests which we're going to the talk very quickly. So I very briefly just mentioned them, but Dr. Cooper is going to talk about it. So she had a cystic fibrosis mutation check, which was in carrier, and she did a torch screening, and it come back that CMV IgG was negative, but IgM was equivocal, and all the other screening come back negative. She actually didn't come back to any of the follow-ups. We tried multiple times to contact her, but she didn't come up. And she just presented in labor at 38 weeks in a spontaneous labor. Have a normal vagina delivery of a baby girl, 3,010 gram, APGAR 999, and post-delivery neonatal hearing test failed twice. So I'm going to invite Dr. Celia Cooper to come with this case. Dr. Cooper is the head and clinical director of microbiology and infection disease at the Women and Children Hospital. She has worked in the Communicable Disease Control Branch at the Department of Human Services at Flinders Medical Center and at the Royal Darwin Hospital. And she has established and managed a statewide hospital-required infection surveillance and control program. Her area of interest include public health, infection prevention and control, antibiotic-resistant stewardship, and infection in pregnant women, neonatal, and children.
Yes, I'm Celia Cooper, and I'd like to thank the conference organisers very much for inviting me to speak at this Brian Pridmore forum, which I consider to be a great honour. I actually am going to talk about something that's I think is very interesting and very topical in terms of CMV. It's probably the latest development regarding congenital CMV. So I'm going to talk a little bit about that. But what I talk about during the talk will then relate back to the case, and I think we'll be able to discuss the case using what's in the talk. So congenital CMV, despite what was reported to the register of congenital infections, is actually much more common than that. So the birth prevalence ranges from 0.3 to 1.2%, but on average considered to be about 7 per 1,000 live births. Now, the majority of babies, almost 90% of babies born with congenital CMV are asymptomatic, which probably explains why the numbers that Morgan gave were so low. And so only about 10% of babies are actually born with symptomatic congenital CMV infection. Now, the babies that are born with symptomatic infection have a very high chance of developing long-term sequelae. And it used to be thought that babies born with asymptomatic infection had a very low risk of long-term sequelae, but that's, the perception of that has changed quite a lot now because we have much better ways of diagnosing asymptomatic infection. And in fact, it turns out that the risks of asymptomatic infection cases eventually developing long-term sequelae are also significant, and usually it's an isolated sensory neural hearing loss. So because asymptomatic infection is so much more common than symptomatic infection, even though the risk of individual cases getting long-term damage is less, overall asymptomatic infection makes the greatest contribution to children with long-term sequelae from congenital CMV, being about 66% of the total cases. So just a quick description about sensory neural hearing loss secondary to congenital CMV, because this is the major complication of congenital CMV. It occurs in about 35% of infected children, 55% of children who are symptomatic at birth, and 20% of children with asymptomatic infection. CMV hearing loss can either be unilateral or bilateral, mild or profound. So a child with unilateral mild hearing loss is not necessarily going to come to medical attention, nor are they necessarily going to experience any really serious educational or neurodevelopmental consequences as a result of that. It's the children with profound bilateral hearing loss that are the ones that are of the major concern to the health system. And about 30% of cases of hearing loss in children with congenital CMV fall into this category. This makes up about 10% of all cases of congenital CMV infection. So this is a really significant public health issue. And approximately 50% of this hearing loss is delayed or progressive, which means that these children will pass the newborn hearing screening test and will only subsequently develop hearing loss. So all children who are born with congenital CMV, whether or not they have hearing loss at birth, must be followed regularly, at least until 5 to 6 years of age, to see if they are going to develop later onset hearing loss. The pathogenesis is not really certain. It's thought that there's ongoing viral infection of the inner ear structures, both the epithelium and the neural tissue, which results in a direct viral-mediated injury, plus damage related to inflammatory host response. And it's because of this ongoing viral infection and ongoing viral-mediated injury that children get progressive hearing loss with this infection. So in terms of what kind of a problem is it for us, well, in South Australia, the annual birth cohort is about 20,000, and therefore we would expect 140 cases of congenital CMV infection per annum. Because about a third of those are going to develop deafness, we would expect 49 cases of deafness and 14 cases of profound bilateral hearing loss, half of which will develop subsequent to birth screening. So there are 7 children every year in South Australia with congenital CMV infection that pass their birth screening that will, over the course of time, develop profound bilateral deafness. If you want to compare this with some of the other conditions that we screen for, such as the Guthrie card screening, this compares with 6 cases per annum of congenital hypothyroidism, 8 cases of cystic fibrosis, 1 to 2 cases of PKU. And this Guthrie card screens for 30 different conditions. The vast majority of this are much rarer than the 3 that I've listed. Looking at it from the other way, when you look at children with profound bilateral hearing loss, sensory neural hearing loss, a quarter of those will be due to congenital CMV infection. So how do the babies acquire the CMV? Well, they acquire it from the mother, and this can either occur when the mother has a primary CMV infection during pregnancy, or women who already have had CMV infection in the past where there's a reactivation during pregnancy. This is something else that's rather new. It's always been known that a mother who acquired acute CMV infection would have a high risk of transmitting the infection to the infant. What wasn't appreciated in the past was that there's actually a significant number of women who reactivate CMV during pregnancy who will transfer that infection to their infant, and that's something that we haven't really recognised in the past. Now, the risk of severe long-term sequelae in individual infants is lower in mothers with CMV reactivation. So when a mother has had CMV reactivation, it's more reassuring to her than a mother who's had primary infection. But overall, because so many more women reactivate CMV than actually acquire a primary infection during their pregnancy, the contribution of reactivation of CMV during pregnancy to overall sensory neural hearing loss is actually significant. Infection during the first and early second trimester seems to be more associated with severe CMV than infections that occur later in pregnancy. In terms of diagnosing maternal infection, almost all women with maternal CMV infection, whether it's a reactivation or a primary infection, will be asymptomatic. So we will not identify women with CMV during pregnancy because of the way they present, because they will be asymptomatic. Now, in some countries, serological screening in pregnancy is done, and this is the main way in which CMV is identified in the mother. So we screen for IgG, IgM, and a thing called IgG avidity, which helps to separate out infections that occurred within the last 3 months, where the avidity is low, or more than 3 months before, where the avidity is high. There are lots of problems with serological screening for CMV in pregnancy, which is why most countries haven't adopted it. It's very difficult to interpret the serology, and the mother being infected doesn't necessarily mean that the fetus is going to be infected, because as I've said to you, there are many cases of maternal infection where the infection is not actually transmitted to the fetus. So what about the diagnosis of fetal infection? Well, the most reliable way of diagnosing fetal infection is to collect amniotic fluid. Now, because of the way in which the virus is excreted from the fetus, this is best done after 21 weeks gestation. This is because the virus comes out in fetal urine, so the fetus isn't excreting enough urine into the amniotic fluid until 21 weeks gestation to get a reliable result. You also need to wait till at least 6 weeks after maternal infection to be sure that your result is accurate. Now, if you find CMV DNA in the amniotic fluid, that is very likely then that the child's been infected with CMV. But if you don't find it, it doesn't mean that the child hasn't been infected, because in some cases the child will acquire the CMV later on in pregnancy after you've done the amniocentesis. So when do we actually do amniocentesis? Well, we do it if the mother has just been by chance identified as having acute CMV during the early part of her pregnancy, or as in this case that Morgan presented, where there are some features on the ultrasound that suggest that CMV infection could possibly have occurred. Now, just because the baby's infected doesn't mean it will necessarily go on to develop disease. So how do we tell if the fetus is actually going to have a symptomatic infection as a result of acquiring infection from the mother? Well, people have tried looking at the viral load, that is the number of viral particles in the amniotic fluid, to see if that relates with fetal damage. there are conflicting results. Some studies have shown that high levels of CMV virus in the amniotic fluid correlates well with damage to the fetus. Others have shown less relationship. The fetal ultrasound can be helpful, particularly when it shows evidence of microcephaly or cerebral abnormalities which are characteristic for CMV infection. What do you do if you identify that a fetus is infected with CMV during pregnancy? Well, we would give CMV Hyperimmune Globulin, which we give once the infection's been identified, so once the amniocentesis has come back as positive, and we give that monthly until delivery. Now, there's not great evidence for this. There is some evidence that it reduces the risk of vertical transmission and the severity of disease in the infected fetus, but there's other suggestion that it may be associated with extra obstetric complications, particularly preterm birth, so women do need to be counselled about this before they're given the hyperimmune globulin. So the main way of making reliable diagnosis of congenital CMV is when the neonate is actually born. And the gold standard is viral culture, and that would be culturing the virus in either the urine or the saliva within the first 2 to 3 weeks of life. Everyone now pretty much has moved from viral culture to a PCR test, which is where you just detect the molecular material, the DNA of the CMV virus, because this is a lot cheaper to do and there's a much more rapid turnaround time because it takes quite a long time to grow the virus in the laboratory, whereas the PCR result will be back in a matter of hours. You can also check for the presence of CMV IgM in the neonatal blood, but this is only present in 70% of infected babies, so the absence of it doesn't exclude infection. Now, you need to do this all within the first 2 to 3 weeks of life, because after 3 weeks of age, you can't distinguish whether the baby was infected during intrauterine or whether it was infected immediately after delivery. So if you don't identify any problems until after 3 weeks of age and you want to know whether the baby had congenital CMV, it can really only be suspected on clinical grounds. Some people do go back to the Guthrie card and make a solution from the blood, little portion of blood on the Guthrie card, and then do a PCR test on that, and that can help. And when children present with deafness, say at 9 months or 12 months of age, we can go back to the Guthrie card and test that to see whether or not the baby has congenital CMV. However, we need to remember that the amount of CMV in the blood is generally much lower than in the urine, and so you usually need to test the blood spots 2 or 3 times to make sure that you've got a positive, that you've definitely not got a positive result. And false positives can also occur potentially because one Guthrie card can contaminate another if they're not stored carefully. So what about babies that are asymptomatic at birth? So sensory neural hearing loss, as I've said, occurs in up to 20% of cases of asymptomatic congenital CMV, and the majority will have late onset or progressive hearing loss. Therefore, the routine physical examination and newborn hearing screening will miss these children who subsequently develop sensory neural hearing loss secondary to congenital CMV. So what's been proposed is a combined approach where you do newborn hearing screening and CMV screening at birth to detect children with asymptomatic CMV who may be at risk for developing postnatal hearing loss. And you can then follow those children up. So several methods have been suggested as a screening tool for CMV, including the testing of blood, saliva, and urine samples. So you can't do culture of these samples as a screening test because we would have to do 20,000 cultures to screen every baby born in South Australia, and this would be very, very time consuming and very expensive and therefore not suitable for mass screening. However, the Guthrie card spots are collected for every baby, so it's been very tempting for people to think, well, we could just use the Guthrie card to do the screening. However, this is not a good screening test because, as I've said, not all babies with congenital CMV will have CMV DNA in their blood. They may just have it in the urine. And so you miss about 80% of cases of asymptomatic congenital CMV if you screen using the Guthrie card, unfortunately. You can screen urine specimens, but they're a bit harder to collect. The easiest ones to collect are saliva samples. So this is being done now in parts of the world where they just put a little cotton tib swab in the mouth of the infant. It doesn't need to be tested when it's still moist. It can be just dried and tested later on. If you do this type of PCR assay, it has a very, very high sensitivity and specificity, meaning it's very likely to pick up all of the cases and not pick up any false positive cases. However, you can occasionally get false positive results because babies who've come out through the birth canal or babies who've been breastfeeding can get some of the CMV in their mouth if their mother's excreting it without actually being infected themselves. So a positive screening result always has to be repeated. And so the use of dried saliva swabs is thought to have the greatest potential for mass screening for congenital CMV in newborns. What about treatment? Well, symptomatic CMV, when a baby's born and you want to identify whether or not that child does have congenital CMV, you need to do a thorough physical examination, a full blood count, liver function tests, serological screening for CMV, PCR of the blood and urine or just the urine, as well as a cranial ultrasound, the newborn hearing screening, and you need to have a look in the back of their eye. The sorts of things that might be consistent with CMV would be microcephaly, other neurological features, seizures, intracranial calcifications on ultrasound, inflammation at the back of the eye, of course deafness, enlargement of the liver, abnormal liver function tests, abnormal blood tests, and just generally a small for dates baby. Now, in babies that present like this, where you've diagnosed CMV and they have physical abnormalities, the standard of treatment now is to treat those babies with Ganciclovir. The first study that demonstrated this was done about 13 years ago, and what they did was they used intravenous Ganciclovir for 6 weeks in the most severely affected babies, the ones who had central nervous system involvement. And what they showed was that you could improve hearing outcome at 6 months, but the effects waned over time. So the next thing that they did was to look at using an oral treatment that's the equivalent of the intravenous treatment, but giving it for 6 months rather than 6 weeks. And what they found was that this did result in improved hearing outcomes and developmental outcomes in the longer term, and that these benefits persisted at 12 and 24 months. The main side effect was neutropenia, and that didn't require the cessation of therapy in any of those patients, and all of these babies had the treatment commenced in the first 30 days of life. What about treatment of patients with asymptomatic infection? Well, there's been some suggestion that a higher viral load in the blood of newborns, if you obtain that in the neonatal period, correlates with a higher risk of hearing loss, and that a low viral load in asymptomatic children is associated with a lower risk of hearing loss. This is still somewhat controversial because there are conflicting findings, but the most recent study from 2014 suggests that there is a sort of a threshold level of viral load above which you can expect that the baby is much more likely to develop deafness. So the importance of this is that if a baby is born with asymptomatic infection, you know they've got congenital CMV, so you identified it on screening, you could do a viral load on the blood, and that would help you to narrow down which of those babies was going to be the ones that went on to develop sensory neural hearing loss. And maybe in the future you could possibly look at offering those babies treatment, but we need to do the clinical trials to demonstrate that treating in the asymptomatic babies rather than the symptomatic babies will also prevent hearing loss. So is it a worthwhile goal? Well, first of all, is it a public health problem? Well, I would say absolutely it is. We've probably got 50 babies born each year in this state with congenital CMV. 14 of them are going to be profoundly deaf as a result of that, and half of them will be missed on newborn screening. Most of these cases are going to come from asymptomatic babies that won't be recognised at birth by any other way than actually doing a screening test. Do we have a acceptable screening test? Yes, I would argue that we do, and in fact this test is being done, trialled at the moment on the IMVS when we have babies born with congenital CMV that we know about. We take a saliva swab and they are working up an assay which is working very well. This costs about $25 a test at the moment. Maybe in the future, if we identify that the baby's infected with CMV, we'll do a viral load, and maybe we'll eventually treat those asymptomatic babies to try to reduce their chances of deafness. How could we actually roll this out? Well, we already have a newborn hearing screening program, and identifying babies earlier will result in earlier provision of hearing aids, cochlear implants, speech therapy, etc., which we know significantly improves outcomes. The annual cost for screening the birth cohort would be $500,000 a year, so I don't know, we have to come to some kind of judgment about whether or not that's a worthwhile.
We used to counsel 10% risk of asymptomatic babies at birth. 10% will have some neurosensory. You said 20%. So
yes.
That's a number we should start quoting now.
Yeah, that's a new finding, and it's basically related to the fact that now there's much with the salivary PCR screening, with the urine PCR screening. I think a lot of those figures came from the days where babies would have, say, had culture of the blood or culture of the urine, which is less reliable. So by having more sensitive tests now, we're being able to identify more children to follow. We're following them for longer, and so we're picking up more of the late onset deafness, and that's the primary problem with the asymptomatic infection, is the late onset deafness. So now with large cohorts like the cohort in Alabama, in Birmingham, Alabama, that's been followed for many, many years, a very large cohort, that's identifying that actually even with asymptomatic infection there's really quite significant risks of sensory neural hearing loss.
Why can't the PCR urine test be done on the mums is one question. And the other question, if a neonate gets a CMV infection, can it have an effect on the hearing as well?
Yes, very good questions. Well, first of all, in terms of the CMV in the urine of the mother, if a mother's got an acute primary infection of CMV, she will excrete CMV in the urine for a variable period of time. I mean, babies excrete for years, but mothers will often excrete for much less. A woman with reactivation of CMV will not necessarily excrete CMV in the urine. So that's that. It's not very reliable. The business about whether or not postnatal acquisition of CMV has any impact on the baby in terms of long-term development is still quite controversial. There is some suggestion that very preterm babies who acquire postnatal CMV from mother's milk, which is the normal way, certainly we know those babies can become quite ill. Some of them will die, but some studies in Germany are suggesting that there are subtle neurodevelopmental defects which often aren't apparent until after 8 years of age, when you're able to do more complex neurodevelopmental testing, that is actually having an effect. So we do treat babies with postnatal CMV acquisition under certain circumstances if they're symptomatic.
I just wanted to ask, because growth restriction is one of the symptoms of CMV disease. I don't know if it can be just isolated growth restriction. So till the time universal screening comes in, is it worthwhile, if we have a growth restricted baby who we don't have an apparent cause for growth restriction, at least all of them, we should be doing a urine or saliva testing? Or do you think it's...
Well, I don't know. I would have to... I'd have to look into it, because I don't know what proportion of babies will present with isolated IUGR and no other features of CMV, so I'm not sure. I'd have to look it up and let you know. But certainly I think we do need to be aware that CMV is more common than has been identified through the birth register because there's so many asymptomatic cases, and also they're not always recognised. So I think the ability to diagnose CMV infection in the baby at birth will make a very great difference to the way in which those babies are actually examined, followed up, that, you know, subtle neurological signs will not be perhaps dismissed or ignored. You know, they'll be recognised for what they are.
Thank you so much. So I just go to the next. Thank you.